May Dr. Ravi Shankar co-host. If sir can speak, then I think we're good to go. Ravi Shankar sir, if you can just confirm if...
Can you hear me?
Yes, we can. Now we are good.
Yes. Yeah. Sorry, I became a bit late. Yeah.
Yes.
So is he there?
Yeah. We'll begin, sir. Just give me a second and we'll start. Namaskaram everyone and welcome to today's session. Today's IAP Twin Cities branch postgraduate clinics and a warm welcome on behalf of the entire executive board of IAPTCB 2022. We're just on the last day of July today, and a big thanks to all of you who have been a part of IAP CPR Day celebrations and also IAP ORS Week celebrations. It's very heartening for us that all of you have joined hands, and we've had programs across the city by all the hospitals and the clinicians, and it is, I'm sure, going to make a big impact in advocacy for ORS and zinc in diarrhea, and of course, the life-saving CPR. We'll continue our mandate of ensuring postgraduate clinics once every month, and this month we're very thankful to the management of KIMS Cuddles to have a very interesting case of a newborn with ascites and hepatosplenomegaly, and also to the teachers, or I would say the examiners today, Dr. Nalinikanth and Dr. Ravi Shankar, both of them very senior neonatologists. Very often we tend to have case discussions for 10-15 minutes, and sometimes it feels as if it's a very incomplete meal. But PG Clinics is one opportunity where just one case for almost 90 minutes and in-depth discussion from the symptoms till the management. And this is almost equivalent to the postgraduate final year case presentation exam. So very thankful to the postgraduate who will be presenting today, the fellow from KIMS Cuddles. I'm sure they'll have a wonderful experience, and also thankful to the teachers. I'll now request our President, Dr. Sunkoch Bhaskar sir, for his inaugural remarks.
Thank you, Dr. RSV. Thank you. Yeah, distinguished experts, Dr. K. Ravi Shankar, Dr. Nalinikanth Panigraha, and mentor, Dr. Aparna, presenter, Dr. Sujana, and the really respected participants. Particularly, we could see the senior most people like Dr. Tudum Anand, Dr. Srinivas Medalli, and Dr. Tilak sir. I'm sure the other PGs probably they had a hectic work during these weekdays, and probably they are taking some rest, and I'm sure they will join us. So I welcome you all to this 7th IAP Twin Cities branch PG clinics. We have been doing it successfully every month without fail. Though we had a big Central Zone conference just 30 days ago, we thought we should do it. We should not miss it even during that month. So that's the reason why we took it up. And this PG clinics has so many firsts. This is the first PG clinics after the Central Zone conference. And this is the first PG clinics on a newborn baby. We had 6 PG clinics earlier, but most of them were on infants, children, but not on newborns. And this is first time to fix a long case in such a short time. My special thanks, heartfelt thanks to Dr. Aparna. Believe me, I spoke to her with a lot of hesitation because I had some experience about organizing PG clinics. Within 4 minutes, maybe less than 4 minutes, she stopped her activities, everything, and fixed this program, probably by talking to her presenter. She said, sir, we are here. That gave me immense satisfaction and great confidence. Because of you people, we, the organizers, though we are not experts, we are learners, we could do all these programs for postgraduates. My special thanks once again to Dr. Aparna. And this is the first time to have Arangetram for renowned experts Dr. Ravi Shankar and Dr. Nalinikant. Unfortunately, we could not accommodate during our past academic activities. Sir, we apologize for that, but in future, we'll definitely accommodate you people. There are so many academicians in our Twin Cities branch. It's becoming very difficult, but you are there in our minds. And once again, I thank you all. And lastly, I request you all to participate in this upcoming World Breastfeeding Week celebrations and do it actively at your workstations so that we should be the champions for the breastfeeding. Particularly you, the neonatalists, your word goes a long way for mothers, for KMC or for breastfeeding or for so many other things. So with these few words, I wish you a great learning experience, and I thank all the participants and the mentor, experts, and the presenter. Thank you, and over to Dr. RSV.
Thank you. Thank you. And I'll now welcome Dr. Aparna, the Chief Neonatologist of Kim's Cuddles Hospital, Kondapur, to say a few words, one about her hospital and also about the case which she is presenting through her fellow today. Over to you, Dr. Aparna.
Thank you very much. My sincere thanks to IAP Twin Cities branch, particularly to Dr. Bhaskar sir and Dr. RSV Sri Krishna for your constant support and for giving us this opportunity today. We are very excited, thrilled to be presenting this case. I think Dr. Sri Krishna also mentioned introducing the unit. So Kim's Cuddles is a neonatal unit and a pediatric unit, of course. And we've been fortunate to start training fellowship programs in NNF and IAP in the last 1 to 1.5 academic years. So Dr. Sujana is one of our fellows. So as of now, we are a 20-bedded, I could say, tertiary to quaternary care setup. We are doing ventilation and high-frequency neonatal transports, nitric. We have also started doing ECMO. And hopefully we would be able to expand our the expertise and constantly keep learning and evolving in the years to come. Today I'm very happy to welcome our presenter, Dr. Sujana, who is our IAP NeoChap neonatal fellow. So this is a challenging case, a preterm newborn who presented to us, referred to us in the 3rd week of life with symptoms and signs suggestive of acute liver failure. And without standing between the presenter and the delegates, I think I'll directly hand over to Sujana. Sujana, can you unmute yourself? And you try once to share your screen. If it's not happening, I'll do it from my end.
Dr. Aparna, shall we invite the experts to say a few words about?
Right. Sorry. So again, my sincere welcome to the experts. Dr. Ravi Shankar sir, we all know him very well. Director of Soumya Hospital, DM Neonatology from PGI, one of our senior most neonatologists in the city, and a great source of mentorship and support whenever we need a support. I've called sir whenever we have had a difficult case, whenever we have had a difficult family, and sir has always been helpful. I also welcome Dr. Nalinikant Panigrahi, consultant neonatologist from Rainbow Children's Hospital. Again, an excellent academician, an avid speaker, a good friend. Thank you, sir, and thank you, Dr. Nalini, for joining us. Could you please share a few words? Sir?
Yeah, Doctor. Yeah. A very good morning to all of you. And see, as much as, because, these, cases teach all of us. It's just not only the student who is presenting or the mentor who is guiding, but the people who hear, who want to, the way they present and all. So we also actually enjoy as much as the presenter, and it's a very nice initiative by the IAP, because this is what actually which drives us. Clinical cases are the ones which actually is the driving force of our life, because most of the excitement comes from seeing good, cases, how it has been evaluated, how it has been treated, managed. Because every day in, day out, although we may have 10 years of experience or 20 years of experience or 40 years of experience, we would always find many things, this one, challenging for us. And I hope today's presentation will go in the same lines. And I wish all the best to the presenter.
Thank you. Dr. Nalini?
Good morning. Good morning to all of you. So I'm just waiting to learn from these cases, because as we know, the greatest teacher, we all teach, we learn, but the greatest teacher for a clinician is the patient itself. When patient and the disease process teaches us a lot, as Dr. Ravi Shankar sir highlighted, we are learning from all the cases, and it's a never-ending phenomenon. So we wish all of you is happy learning today through this case. Let's do without taking much time to start. I will still invite the speaker and the moderator to start the session.
Thank you very much, sir. Thank you, Dr. Nalini. I must acknowledge that this was a challenging, a very complex case. Maybe we have still not reached the complete diagnosis. We are awaiting an important genetic investigation. Nevertheless, as you all rightly pointed out, we thought that the focus would be on developing an approach to the clinical syndrome, and to try and discuss the various important modalities of diagnostic evaluation and management, both general as well as specific. So with those words, I'll hand over to Dr. Srujana. I think you can make it full screen, Srujana.
Yes,
slideshow, and begin.
Good morning, everyone. I'm Dr. Srujana, fellow in King's Cuddle. I like to present a case regarding neonatal acute liver failure. This is the case. A single live, very preterm 29-weeker male baby delivered by the emergency LS. Indication is anhydramnios.
Srujana, one second. I think the slides. Apologies, Srujana. 1 second. I think the slides are not moving. Can you make it full screen and then
full screen?
Proceed. Then it's not. Is everybody else able to see the full screen view? I'm not able to see it.
No, we are not able to see.
Okay. There seems to be. Just stop screening and try once again, or you leave it. I will project from my end, Srujana. So I hope the slide is moving now.
Yes.
Okay. So you just speak, Srujana. You see, look at the slides and speak. I'll share it from my end.
Okay. A single live, very preterm 29-weeker male baby delivered by the emergency LSCS. Indication is anhydramnios and absent and diastolic flow with a birth weight of 1060 grams. It's an outside private hospital. To 26-year-old G5A4 mother. Baby had cried immediately after birth. His ABGA score is around 7 and 8 at 1 and 5 minutes respectively. Coming to the maternal history, she is a 26-year-old woman with G5A4 and second-degree consanguineous marriage. First 3 pregnancies, she was conceived after ovulation induction and had missed abortions. Fourth one, she conceived naturally, but MTP was done where her double marker test was positive for trisomy 21, and also her ultrasound scan showed increased nuchal translucent thickness and complex cardiac anomaly with TR. So there is a intrauterine fetal demise. So they have done the MTP. In the same after this, in view of repeated miscarriages, everything, genetic screening was done where the parental karyotyping was only given, which was normal. And the present pregnancy, coming to the present pregnancy, it was conceived spontaneously, and the antenatal scans, which was done, all were normal. And mother had PPRYM for around 5 hours, where antenatal steroid complete dose was given, and the mother blood group is A positive, whereas baby is O positive. She doesn't have any history of fever with rashes or genital infections, any blood transfusions, GDM, hypothyroidism, any history she doesn't have. Baby was delivered and then baby was admitted in NICU for respiratory distress and then preterm care. At the time of immediately after birth, this is the course which was happened at the referred hospital. At the time of the birth, baby had respiratory distress with a disease score of 3/10. So they had kept in the bubble CPAP with PEEP6, flow 5 and FaO2 25%. And then by day 7, they have went off to HFNC, and then baby was on nasal prawns from day 9 of life till 17th day. On 17th day, baby had recurrent apneic episodes with persistent desaturation, which was not improving. So they have intubated and then connected to the mechanical ventilator with high settings, with PEEP of 22 and PEEP of 6 and FaO2 on 100%. Sir? Coming to NEC, they have baby initially baby was kept at NPO for 24 hours in view of arson and flow, and then minimum tropic feeds were started on day 2 of life. And then on day 3, baby in view of distended with 10 abdomen, they had taken an X-ray which showed dilated and thickened bowel loops. So in suspicion of NEC 2A, baby was kept NPO. And then, but again, it was continued day 7. Again, they have started the feeds and then they were hiked as per the protocol. Then on day 17, again, baby was sick, so they had kept an NPO. In coming to the sepsis wise, initially baby was started on Taxim and empirical antibiotics in view of probable sepsis. Then on day 3, baby was dull and had counts, everything was done, which shows thrombocytopenia and declining trend. So antibiotics, they were updated to injection meropenem, colistin, and vancomycin, and antifungals like fluconazole. On again on day 4 of life, baby had in like poor peripheries with persistent hypotension. So initially they had given the bolus, which was not improved. So they had started on inotrox with the adenine at 1 mg per kg per minute and dopamine 10 mg per kg per minute, which was started and it was even continued at the time of referred. Like on day 17 also it was continuing. These are the events which has happened on the day 17. Baby was intubated in view of recurrent apnea with desaturation. And then 2-day echo, which they were done, they showed LV dysfunction. So they have started on the dovitamin at 10 mg per kg per minute. Baby also had oral and nasal bleeds. So CBP workup was done, which showed HB of 7.9 and platelet of 3000 per cubic millimeter. So they had given one transfusion of both HTP and packet RBCs. Baby was hectic, so they had done LFT, so which was a deranged showing raised TSB around 27.4, of which direct is elevated even more than 50%, 15.2, and indirect it is 12.2. Albumin, it is at the lower end, 3 grams per deciliter, and the enzymes were also slightly increasing, SGPT 41 and SGOT 95. Here, renal, baby had a decreased urine output, which is less than 1 ml per kg per day. And then the RFT workup was done, which showed elevated urea 101 milligram per deciliter, and creatinine, it is around 1.2 milligram per deciliter. In all these views, baby, they had referred to our hospital like, for further management. At the time of admission, baby was brought in an ambulance with ET.
So can we stop here for some time?
Yes.
What was your history?
Sir?
Can you, what do you make out of the history? So you had an extremely preterm baby.
Extremely preterm baby with mild RDS and deranging LFT with clinically ectric baby, that on late prolonged jaundice, with deranging like renal functions. with the LV dysfunction there.
Okay. So what do you think of the, because see, this baby, ultimately you are presenting a case with, hepatosplenomegaly and ascites. And do you get any clues in the history as to what might be the etiology? She had some, abortions. And then, so what is it,
One, she had previous miscarriages are there, and oligohydramnios is there, anhydramnios, all these. One, like neonatal hemochromatosis, we may suspect, sir, because they also the previous miscarriages.
So, hemochromatosis is
Alloimmune. So, previous death will be one thing we can think.
no, but what do you think are the causes of, in general, not in pertaining to this case, what do you think is the cause of recurrent abortions? Is there, and what in general would be the causes of?
Most of them are in first trimester, so mostly genetic.
Genetic. Okay, it is all of them were in the first trimester only.
Yes, the first 3 were in the first trimester.
And then you had a baby with anomaly.
Yes, sir. So yeah, the fourth pregnancy it's with anomalies, cardiac anomaly.
Okay. Is it also possible that this was some kind of an intrauterine infection?
Maybe, sir. Yes, sir.
Okay. So, so you had those recurrent abortions. This becomes a very precious pregnancy and precious baby also. And what kind of intrauterine infections can lead to recurrent abortions?
Torch infections.
What torch infections can cause?
HSV, CMV.
So all of them can lead to recurrent abortions. This HSV is not a cause of abortions. Usually HSV is a perinatal infection, so it won't cause. Yeah. So the cytomegalovirus or toxo or rubella, these can cause abortions only in the primary infections. These are very, very unlikely to cause recurrent abortions. So that is only when the pregnant woman has a primary infection in the pregnancy, then only it can lead to it. What else can be the cause of it? Is it possible that, so what is the presenting symptoms of congenital syphilis? Syphilis in the pregnancy, if she's, untreated. So they can also have this kind of a presentations where the initial pregnancies are, abortions, and then they go into prematurity. Now, with regard to the management, if you just go back to the slides, please just go back to the slides once. Aparna, can you just go back to the slides? No, there's still more on day 1 and day 2. Yeah. So, so there was. Do you think whatever management has been done in the referring hospital was appropriate? Do you find anything odd in this, or is it all the usual manifestations, usual course of such a premature baby?
No. One surfactant we don't know actually why we had delayed surfactant we didn't give for this baby.
So what are the indications for giving surfactant in a premature baby?
the baby is on CPAP and FA-water requirement is more than 30%.
So here it is only 25%. So, so you would give surfactant if the oxygen requirement is more than 30% in a case of RDS, or you happen to intubate the baby in the delivery room, and then you don't know whether it's a case of RDS or not. So you can sometimes give it, prophylactically. They had not given the feeds for the baby in the first 24 hours. So is it okay not to give the feeds in the first 24 hours?
Actually, now early initiation of feeds is better.
No, but they had a concern that it was it was a case of severe placental insufficiency, and the Dopplers showed an absent end diastolic flow. So was it okay for them to? So what does the recent evidence say about stopping the feeds? Is there any evidence present? Okay, so I think we don't have a strong evidence to this. It's always good to start the feeds if the baby is hemodynamically stable, and irrespective of whether it is an absent, because we don't have any strong studies to say if those. I think this was 28 weaker or 29 weaker?
29 weekers.
29 weekers. So those who are extremely preterm, probably we have to withhold for a day or two. But those who are about 29 weeks, I think probably we can, because we don't have, because these days recent evidence is also, and the meta-analysis is also showing that there's no strong evidence to say that withholding will help in decreasing the incidence of NEC. Next slide. When the baby they had to start some kind of antibiotics, and when this baby was sick, what were the antibiotics which was started on day 3 of life?
Meropenem, colistin, Vanco.
So what do you have anything to say with that kind of, and also fluconazole also. So what does it mean about starting such kind of a combination on day 3 of life? What is
gram-negative infection they have to cover more,
so 4 different antibiotics, and especially colistin also starting on day 3 of life. So I think this shows that probably we are, see, as far as the usage of the antibiotics is concerned, there has to be a proper protocol, and a kind of stewardship has to be there in this. If your unit is using these kind of antibiotics in the first 2-3 days of life, either it shows that there is a lot of infection in the unit, or we don't know what are the organisms which are causing infections. So what are the various organisms and all. So this kind of a combination, what is the association between antibiotics and the neonatal morbidity? That does it actually help? If you start antibiotics, a lot of antibiotics initially, does it actually help? So how does it impact the baby's future?
No, sir. Lot of antibiotics, it's better to.
Yeah, so these, antibiotics are not good because it will obviously increase the chances of the development of the drug-resistant organisms. And says, secondly, usage of antibiotics itself will lead to some kind of an inflammatory syndrome in them. And it increases the chances of various, morbidities. So the more you use the antibiotics, the more antibiotics are used, the more would be the kind of, morbidities, including the NEC also. So it is always better to be selective and to choose the antibiotics as wisely as possible. Next slide. So what is your differential diagnosis about the presence of the jaundice on day 70 of life?
Yes, sir. Neonatal cholestasis was there, sir.
Okay, so you also had cholestasis, you had the enzymes being slightly elevated, you had there was associated thrombocytopenia, anemia. So what is this kind of a syndrome? What is the differential diagnosis for this presentation?
One is differential. One, it may be infections, sir. In infections also, there will be rise of all these, and other even metabolic causes also they may. But
so was this baby on any kind of TPN?
Outside, we are not sure, sir. Actually.
Okay. And okay, you can continue.
Shall we ask Srujana to just summarize the history, sir, so far just for the benefit of the. Srujana, can you just summarize the history and the events until now, until the point that baby reached our unit?
Yes, ma'am. Baby, one, it is a very preterm antenatal figure.
Srujana, just a second.
Sir.
Just a second. You summarize the case, but with a little bit of formatting, you summarize antenatal risk factors, which are the clues for the disease, and what are the evaluation done. One line you can finish: antenatal risk factors and the clues to this disease till now. Then perinatal events of the baby, the preterm babies, what are the perinatal protective and non, which we could not protect the baby from preterm morbidities in the perinatal time, and the resuscitation details, whatever available to you, the perinatal history. Then the neonatal course till it comes to you. And these three components, if you highlight clearly, then it will give a message to us, summarize later the case. You summarize, but with these three formats.
Okay. Antenatally, one mother doesn't have any fever with rashes, sir, or any lymphadenopathy. She doesn't have any blood transfusions also.
Please summarize positive findings and negative findings, whatever you found in history. What are the positive? I will find IUGR, EDF, and anhydramnios. The three of the findings which are a clue for something here. In the recurrent history of abortion, we are getting ADF, IUGR, anhydramnios. Is it a clue?
That is neonatal alloimmune.
No, I'm not going to disease. Don't name any disease here. We are not into disease here. We are analysis, symptomatology, and entering into a syndromic analysis. Later we'll come to disease. Please don't go to disease.
Yeah. So can you start your summary, Srujana? So this is a 29-weeker.
29-weeker with emergency LSCS with mother antenatally mother.
The primary
Birth
reason
weight of 106 kilograms.
why born premature of 29 weeks should be highlighted in history, because there's many of the morbidities may be related to the premature delivery. So
Because
the presentation we should know why the baby born LSCS with clarity, and do some protection practices done for these to prevent morbidities, or we missed it due to unavailability of those practices.
Prematurity is because baby in case of anhydramnios, mother already came with PPR sir, and having anhydramnios and ultrasound showing absent end diastolic blood flow. So we had to deliver the baby.
Yes, proceed.
So let me just attempt, Srujana, on your behalf, just the important findings. So this is a 29-weeker, very preterm male baby, 1060 grams, delivered preterm due to anhydramnios, premature rupture of membranes for 5 hours, not prolonged, but preterm pre-labor rupture of membranes with absent end diastolic flow and severe anhydramnios, with complete course of antenatal steroids. There is no history of antenatal magnesium sulfate. Born to a 5th gravida mother with history of 3rd-degree consanguinity, 4 previous miscarriages, first trimester miscarriages, which included 3 missed abortions and 1 medically induced termination following the presence of some markers of chromosomal anomaly in the form of increased nuchal translucency and heart defect, cardiac anomaly in the fetus. Parental karyotyping, both husband and wife being normal. And during current pregnancy, the mother had an apparently uneventful antenatal course in the form of no history of fever, rash, lymph node swellings, no history of receiving blood transfusions during pregnancy, and no history of antenatal ultrasound abnormalities except for anhydramnios and absent end diastolic flow. Right? So far, I hope we have captured the antenatal and perinatal aspects. So in similar fashion, can you also summarize the postnatal course from birth? So baby had respiratory distress requiring?
Baby had respiratory distress requiring CPAP, and then followed by HFNC, and then on normal nasal bronze. Then baby also had NEC. They have suspected of NEC on day 3 of life. Then baby also had a probable septic shock, which was on day 4, and baby had started on inotropes, adrenaline and dopamine. Then and baby was on feeds. It was started on day 7 of life, and on day 17, all the event, like baby had recurrent apneas. With recurrent apneas are there, and also babies having with bleeding manifestation from oral and nasal bleed with anemia, thrombocytopenia, and elevated bilirubin levels, more of direct component with decreased urine output and elevated urea creatinine levels, and LV dysfunction. On echo, it was showing severe LV dysfunction. So baby was on dobutamine. And baby clinically, baby had jaundice. Baby also had ascites with the edema. And hepatosplenomegaly was there.
Right. So you have presented, multiple some signs, some of them being investigation findings, some pertaining to one system, some pertaining to other systems. So how can we put this in a more organized fashion? So let's say you can begin with one system, starting from the initial, from the day of birth until now, or you can kind of trace the events as they happened in real life. So you would probably, this can be better summarized as, so this baby born at 29 weeks was initially managed for respiratory distress syndrome with CPAP, There is no history of any surfactant administration being required, probably in view of minimal FiO2 requirement, and subsequently could be weaned to high flow nasal cannula. The baby was noted to be initially hemodynamically stable. There is no evidence or no history available about the presence of a hemodynamically significant PDA or its treatment. There is also history of feeding intolerance in the form of abdominal distension and aspirates requiring cessation of feeding on day 4 following initiation of minimal enteral nutrition after an initial 24 hours phase of enteral fasting. On day 4, the baby was noted to have clinical deterioration in the form of shock. Hence, antibiotics were upgraded to broad spectrum antibiotic coverage, as you have mentioned. And subsequently, the baby was noted to be gradually improving, feeds were hiked. Again, the baby was noted to have worsening in the form of bleeding, in the form of worsening abdominal distension on day 17 of life, and was further evaluated and found to have prolonged jaundice with direct hyperbilirubinemia, transaminitis, decreased or hypoalbuminemia with decreased urine output, azotemia, bicytopenia in the form of anemia, thrombocytopenia, shock requiring inotropes at a maximum dose of dobutamine 10 mics and adrenaline 0.1 mics per kg per minute, with oliguria with a urine output of 1 ml per kg per hour. So, I hope I have not missed anything. So what are your, broadly, what are the clinical syndromes that we are dealing with?
The case well summarized. I just need two information here because we know this is a multi-organ involvement already at this stage.
Yes.
Whatever initiated, now we know there is a cardiac dysfunction, the circulatory dysfunction. We know there is a respiratory failure requiring mechanical ventilation. We know there is a involvement of bone marrow or blood, I will say. But I want one information to say bone marrow. Was there a leukopenia or a leukocytosis? Because I know 2 bicytopenia is per definition here.
Initially
low and platelets low, but what was the leukocyte status here to say it is a suppression of bone marrow or the leukocytosis was there? Just one information will help us. And second, liver dysfunction in the form of cholestasis we know, but albumin with 3, if the PTINR information will be available, we can know that synthetic function, how it is affected in the liver. So that's probably these 2 information, adding information. The one will give us bone marrow, other will give out information about liver. Well, additional information we probably need at this stage. Then the course we can discuss further.
Srujana, can you answer?
Yes,
What is the status of the site? And Dr. Srujana, this liver function well described. I want to know the PTINR also reflects liver dysfunction only. That information adds some angle to the disease differential diagnosis.
Yes, sir. Actually, coming to CBP, these leukocytes, initially it was normal, sir. It was around 8,000 to 8,500 like that, sir. But after that, there is a falling trend. There is leukopenia around 2,000, 2,500.
Okay. What about PTINR?
PTINR, it was elevated in our settings. So it was around, elevated up to 2.6. So it was elevated. INR and PT is also elevated up to 40 to around.
Dr. Srujana, is it going to help you if knowing only plain cholestasis, one baby with hepatomegaly, one baby having hepatomegaly, cholestasis, and there is a dysfunction in the PTINR? Is it going to help you?
Yes, sir.
The diagnosis, is it going to help you?
So sir's question is, Srujana, does it help, does it make a difference if the baby only has neonatal cholestasis with intact synthetic function, like intact albumin, intact INR, versus a baby who is having direct hyperbilirubinemia with abnormal INR, decreased albumin also in addition?
There is different, with increased INR and decreased albumin, this indicates that the baby is going into liver injury, sir, acute liver injury. Like they're going into phase.
Yeah, it's one of the liver dysfunction. It pointed towards liver dysfunction, not only increase in size or not the obstructive dysfunction. It is synthetic dysfunction means liver cell failure. It indicates as liver cell failure. The cellular function of liver is failing. Okay, you can proceed then. We got this good summary. You can proceed for the description.
At the time of admission, baby was sick looking and baby brought with ET in situ with oral and nasal bleeds, ectric, edematous was there. On coming to the vitals rate, temperature at the time of admission, it was around 36.2, heart rate 166 per minute, respiratory rate 54 per minute, with the SpO2 96% with FiO2 60%. BP, it is around 5 to 50th centile, and the baby was on inotropes.
Yes.
CFT, it is around 3 seconds. Pulses, it fell, but it was not like prominent. Coming to the respiratory system, baby came brought with ET in situ, and so we have connected to the mechanical ventilator with settings of 22.6 by FiO2 of 60%. Bilaterally, air entry was equal. And at the time of admission, baby had subcostal retractions and intercostal retractions with nasal flaring. So we have SS score was around 4/10, and the chest raise, it is adequate for the ventilation settings we had. Coming to cardiac system, baby both heart cells were present, but there was no murmur on auscultation. CRT, it was around 3 seconds. So we have continued the inotropes which we have started. They have started. Adrenaline 1 mics per kg per minute and dopamine 10 mics per kg per minute. Coming to abdomen wise, baby on inspection, baby abdomen was distended, shiny, and there is equal movement of all the quadrants. Umbilicus is slightly everted, and flank seems to be full. On palpation, almost about 5 to 6 centimeters of liver is palpable below the right costal margin. It is firm in consistency. And the spleen, it is around 2 to 3 centimeters. It can be palpable below the left costal margin, and it is also firm in consistency. And when it was abdominal girth, it seems to be distended. Outside, it was around 23. Where we have observed is 25 centimeters, so almost it was increased by 2 centimeters. Here, we couldn't do the fluid thrill and shifting dullness in this case, but in view of flank fullness, we suspected that ascites was there. On auscultation, ball sounds were not present, and baby is passing stools which were yellow in color, but baby was on NPO. There is total, genital wise, there is total edema was present, and the anus patency is seen. Coming to the central nervous system, baby cry tone activity was done at the time of the admission, and AF was at the level. And this is the baby with showing ascites, and there is bleed from the oral and nasal tube bleed is there. So from these findings, we had made a few we can make a few differential.
Sujana, before we go to the differentials, I think it is also important now to summarize the clinical findings. So we have already summarized history, and as Dr. Nalini pointed out in the antenatal pointers, positive and negative history, the perinatal history, including birth history, and the postnatal events. So can you summarize the clinical examination findings?
Yes, ma'am. Respiratory wise, babies having respiratory distress. In cardiac wise, baby still still the baby is in shock, and on inotropes. Abdomen wise, the baby is having hepatomegaly, splenomegaly, and baby is also having in view of bleeding, we can suspect of any coagulopathy, and the flanks were full, so we can suspect of ascites. Generalized edema was present. And CNS wise,
in your abdomen, summary, you mentioned distension with the presence of hepatosplenomegaly. What was the consistency?
It was firm in consistency.
Yeah, so that's again very important finding. So you have firm hepatosplenomegaly with suspected ascites, with anasarca, with clinical bleeding, oral and nasal mucosal bleeding. Was there any skin bleeding in the form of petechial rash or purpura ecchymosis?
Initially, it was not there, ma'am. Later, it was there.
Right. So, it's probably helpful to also capture it here because they're all part of this same syndrome. And the baby also looks pale, isn't it, on general examination?
Yes, ma'am.
Okay, so you can make out pallor, icterus,
Yes,
anasarca, and you have already summarized the respiratory and cardiovascular findings. So in abdomen, you would say that the baby had distended abdomen with firm hepatosplenomegaly with presence of suspected ascites. Of course, you are suspecting ascites based on the presence of flank fullness, which you would be confirming with some investigations, with the presence of anasarca. Anything else? With encephalopathy, hypotonia, clinical bleeding. Any seizures the baby had in CNS?
Initially, it was not the ma'am. After admission on day 3, baby had one episode of seizure.
Right. So, should we go on to the differential diagnosis at this point, or
no? I think she should tell what is the clinical syndrome now. Now that you have the entire clinical examination findings, so is it clinically, it is pointing out towards which kind of an organ involvement, and what is it? So first she must tell about the clinical syndrome and then go into the differential diagnosis regarding the etiology.
In view of more like ascites and hepatosplenomegaly with cholestasis, it's indicative of and coagulopathy, like bleeding.
Can you tell the differential diagnosis for hepatosplenomegaly in a baby who didn't have this at the time of birth, but after 2 weeks started having this? You just leave about all other things. Just try to tell what would be the different causes of it. In the same way, can you tell what is the cause of ascites and this and sarca?
One anasarca ascites may be hypoalbuminemia, may lead protein loss. It may lead to like ascites, anasarca. Splenomegaly, hepatosplenomegaly, it usually seen with one. It can be seen with infections, with the metabolic conditions like galactosemia.
So, what kind of infections can lead to hepatosplenomegaly associated with jaundice?
Hepatomegaly problem, hepatitis 1, even in herpes simplex also there may be hepatomegaly. CMV they have. Enterovirus also they have.
And some disease which is specific to India, especially more common in some parts of India, is it possible?
Sir?
Viral can happen anywhere in the world, but some Indian geographical limited disease which can cause this hepatosplenomegaly, anemia, any possible?
Srujana, you got sir's question?
No, ma'am.
So you were mentioning some viral causes of, viral infections which can present with, acute liver failure, neonatal acute liver failure. So you mentioned herpes and enterovirus and, other, EBV and other viruses. So sir is asking, is there any other non-viral infection particularly in India, which can present with a similar presentation? Can malaria do
First
this?
week or second?
Yes, ma'am. Yes, malaria.
So if a hepatosplenomegaly plus there is a anemia and the jaundice, multi-organ failure, then congenital malaria or later early acquired malaria also can possible. And specifically hepatomegaly with the bicytopenia, an infection which sometimes happens to, an infection causes bicytopenia. And, it's not so common in India specifically.
Bicytopenia is HLH.
I'm asking about infection, which is not common. Like malaria only, it's a parasitic. So infection presentation. So sometimes if you're getting bone marrow plus hepatomegaly brucellosis is possible, which is not common here, Indian part.
Yes, not common. Very rare.
But malaria is common, we have to keep in mind. So the questions we have to actually address here, that it's only hepatomegaly, cholestasis, what you will think of. Hepatomegaly with cholestasis with liver dysfunction, the way it is, what are the differences will come here to mind? If it's the hepatomegaly plus splenomegaly plus liver dysfunction, what are the differences will come? So common is hepatomegaly here, but 3 different presentation can come. Hepatomegaly plus splenomegaly, what are the things in units you will think of? Hepatomegaly dysfunction plus jaundice, what are the causes you will, cholestatic jaundice, direct hypervolemia, what are the things you will think of, what are the differentials? So that will guide to reach to the disease here.
So what are the pointers in this case that this is a case of hepatic failure?
One, it is hepatomegaly, sir. Hepatosplenomegaly, ascites, bleeding. That is.
Yeah. So a baby who is born premature, who had a course which was associated with no feeds or a very little feeds, can also go into, and if the TPN has not been given, then there's a high possibility that this particular baby may go into severe hypoproteinemia, can also have ascites and anasarca. So ascites and anasarca alone is not alone a feature of hepatic failure, unless you say that the ascites is out of proportion to the edema present elsewhere. The pointer is the presence of the bleeding manifestations. So if you have associated bleeding manifestations with this kind of a syndrome and ascites which is predominant, then it definitely points out towards an hepatic failure, unless there is other coincidental things like severe thrombocytopenia and all. So when you have an when you have features of hepatic failure, then your differential diagnosis will get narrowed down. Is it a fungal infection? Can you also, what are the predisposing factors? You didn't tell whether this could be because you told infections. Yeah. You were talking about cytomegalovirus, herpes, enterovirus, and then now you talked about this, malaria also. Can this be a presentation of a fungal infection?
Yes. Yes, sir. They also have this cytopenias with abdomen distension, dull activity.
Okay. Anything else in your clinical examination which you have looked for? Any telltale evidences for fungal infection? Any kind of oral thrush or
no.
skin kind of manifestations anywhere? No. Okay.
No.
So This is a highly immunocompromised baby who has had a lot of problems since the time of birth. So this child can get affected by the usual problems of the prematurity, or we could be dealing with some other illness. So it is really a very challenging case, because whether it is a part of usual prematurity morbidity, or are we having some unusual illness or infection, or some other metabolic problem is to be worked out. So it's really a very kind of challenging case. Yeah. You
So
can
I
proceed
think,
with the next. Yeah.
So had it been, if it had been a plain and simple case of neonatal cholestasis, and if we had not seen these signs of acute liver failure in the form of bleeding, prolonged INR on labs, with evidence of hypoalbuminemia, declining albumin, and encephalopathy, which could be accompanied by hyperammonemia, all these indicative of acute liver failure. Had it just been cholestasis, then our typical thought process would be to try and see whether this is obstructive or hepatic. And of course, obstructive would be one of the top priorities for us to rule out. But notably, infants with EHBA, extrahepatic biliary atresia, or choledochal cyst do not tend to be so sick. They have relatively preserved liver function, unless the obstruction is really ignored for a long time, for months together, and then the obstruction results in irreversible parenchymal changes. On the other hand, neonates who are having underlying genetic metabolic causes for liver failure, particularly neonatal tyrosinemia or galactosemia, or neonatal hemochromatosis, which is an alloimmune fetal liver problem, or some acute infections, particularly herpes. These can more often present with a combination of organomegaly with liver failure, liver cell failure, and they tend to be more sick right at the time of presentation. So it kind of gives us a different spectrum of differential diagnosis.
That's right. Can we move ahead?
These are the differential diagnosis. First, we have the mostly it is of infections, which are sepsis, herpes simplex virus, enterovirus, adenovirus, cytomegalovirus, congenital syphilis, E. coli, hepatitis B virus, and toxoplasmosis. The next one is neonatal hemochromatosis or autoimmune hepatitis. Coming to metabolic liver diseases, the most commonly galactosemia, type 1 tyrosinemia, hereditary fructose intolerance, and mitochondrial disorders. The other one is hemophagocytic lymphohistiocytosis. As the multi-system here, in our case, it was multi-system as so we have also, and thrombocytopenia persistent, everything was there. So we have also suspected MASN post-COVID. And which are the rare causes? These are malignancies like congenital leukemias, neuroblastomas, nephroblastomas, and drug-induced like paracetamol, valproic acid, and other drugs.
Can you tell us why did you include the hereditary fructose intolerance?
Actually,
can it present at this time?
No, sir. Usually at after 6 months, when the complementary feeds were started, it should be present. But there are few studies which shows that they may also present with if the baby is fed with formula feeds, the formula containing fructose, they may present.
I don't think we have any formulas containing fructose. And I know this baby was not on. Okay. And can you elaborate a bit on the paracetamol-induced hepatic failure? Is it possible?
Usually it's not. It's very rare, sir. If that is because of metanol overdosage, it may.
Okay. ठीक है. Next. Yeah, please proceed.
Sujana, can you continue with the presentation?
Yes, ma'am. Now, this is the course which we had done in our hospital. Coming to the respiratory system wise, baby was brought with ETOC2 and view of respiratory distress. Baby was directly connected to the SIMD mode on with the same PEEP of 22 and PEEP of 6 with a rate 40 and 60% FiO2. As the baby had apnea and in the preterm prematurity, we have continued the caffeine. And then baby was admitted on day 17 of life. By day 3 of admission, we have weaned the baby to NAPP mode. Again, on day 22, baby was reintubated. Baby had a persistent desaturation and it was not maintaining. So we have intubated. And we had taken an X-ray, which the X-ray was showing a right side collapse was there. For this, we had done the physio and right-up positioning and then intubation, and followed which the X-ray, the collapse was opened up.
When was this X-ray taken? Was this at admission or was this at the time of reintubation?
It was just before the reintubation. Like right. It was before the.
Go on.
Coming to cardiovascular, 1 minute. Coming to cardiovascular system, baby was on multiple inotropes, both adrenaline and dopamine in view of hypotension and poor peripheries at the time of admission. Later, by day 3 of admission, we had tapered the adrenaline and the dopamine, and we had stopped it. At outside echo, which shows LV dysfunction, here we have repeated the 2D echo. It was showing there is improvement in the LV function. So we have continued the dovitamin at 10 mg per kg per minute. Coming to feeding GI system, we have kept the baby on NPO, and then we have started. We have started the TPN on maintenance fluid, and OG feeds were started after 24 hours of post admission. And then high testosterone. But on day 2, on day 5 of admission, baby had similarly the tense abdomen, and X-ray was done, which was showing dilated bowel loops. Again, we have kept the baby on NPO. Coming to hepatic wise, there is a deranged LFT with elevated direct bilirubin and indirect bilirubin. Hypoalbuminemia, it was persistent, even it was reducing time. So we had given albumin transfusions thrice. And in view of deranged coagulopathy, we had given FFP, multiple transfusions were given. And cholestatic regimen was added in view of deranged elevated direct with hepatomegaly. And then ultrasound was taken, which shows gallbladder sludge with minimal ascites with mild hepatosplenomegaly, but there was no any evidence of IVC or renal vein thrombosis. Coming to renal, baby had oliguria at the time of admission, and RFT was deranged with the creatinine 1.8 and urea 144, which was even more increasing. So we had started on Lasix infusion, and the urine output and the RFT was improved by day 3 of admission. Then hematologically, baby had bleeding manifestations. Along with that anemia, it was there. HB, there was falling trend of HB. So multiple LRBCs transfusions were given. And thrombocytopenia, it is persistent, which was almost about 3,000 to 8,000. It was persistently low. And leukopenia, it was also persistent. On further follow-up, there is leukopenia, which was reduced up to 2,000. Coming to central nervous system, baby cry tone activity was poor, and on day 4 of admission, baby had one episode of seizure activity, for which we had given one Nevipill dose loading, followed by the baby was kept on maintenance dose. NSA was done, and it was normal. We have also done the septic screening. So with that septic screening, it showed Klebsiella oxytocin positive. So we have treated with antibodies based on its sensitivity levels. And acyclovir, it was also started as we don't know about the mother in view of HSV infection and in view of leukopenia with a low NEC, felagastrin was added on day 5 of admissions. As multi-system involvement was there, so we have also done a workup for COVID, which shows IgG positive, whereas IgM was negative, and D-dimer LDH levels were also elevated, CRP is elevated. So we had in view of MSN, so we had given IVIG 2 gram per kg over 48 hours. These are the investigations workup which we had done. Here HB, it was we had given multiple transfusions, but still the HB was falling. It is in the decreasing trend. In the last, it is around 8.4. And platelets, if there is a persistent thrombocytopenia was there, even after several transfusions. And WBC, it is showing in decreasing trend, which is low. PT, initially APTT, PT both were elevated, but on further PT and INR, it was showing increasing trend. Along with the bleeding manifestations were also there. And urea, it was at the time of admission, it was around 144, and creatinine is 1.2, which was increased to 1.8. And then it was normalized by day 5 of admission. And CRP, it is in the increasing, it was elevated, which is around 159.2. Serum, we have also done other work of serum ferritin, serum triglyceride, where serum ferritin is elevated 1404 nanograms per ml, and serum triglyceride it was normal.
So I think there is a lot of information coming here. A couple of things which I would like to upfront clarify were while you were speaking. So this culture positive sepsis Klebsiella, this was from the admission culture, isn't it? And just to clarify, this was a pan-drug resistant Klebsiella. It was resistant to almost everything. I mean, third generation cephalosporins, colistin, and it was only sensitive to TG-cycline. And luckily, it was sensitive to amikacin. So there was not much of option than to continue these two drugs. And acyclovir was started without obvious lab evidence of herpes infection, as per the I think typical ALF management protocol, where acyclovir is something that is recommended upfront while the workup for infections is being sent. So I think you will talk about the specific infection related workup later. And you haven't mentioned about the antifungal. You know, the baby was already on an antifungal. So
antifungal also, yes, ma'am. Baby was an antifungal.
What was the
liposomal anti-PA?
This baby was continued on liposomal, was given, I think, initiated on liposomal amphotericin B in view of the renal dysfunction. And one correction I wanted to, while talking about the renal issues, I think you mentioned in view of elevated creatinine, Lasix infusion was started. That's not the typical reason for giving Lasix infusion. Yes, so it was a decision to give Lasix infusion along with the protein albumin infusions in view of anasarca. Albumin Lasix is not going to really help when there is azotemia of this extent, isn't it? So yeah. So what do you see from the hematological workup and the PT-INR and renal function? So there is kind of ongoing anemia despite multiple transfusions. You're seeing a declining trend of the white cell count. There is worsening leukopenia, and thrombocytopenia seems to actually be progressive, again, despite platelet transfusions. You have coagulopathy, deranged INR, and the prothrombin time is in fact getting progressively deranged. So with an elevated ferritin. So shall I also go to the other investigations, and then should we discuss about this, sir and Dr. Nalini?
Yeah, we can see all the investigations at a time. So if it is in tabular form, it will be easier. We can see quickly.
Right. Yes, Rujana.
This investigation was liver infection, liver investigations, where TSB it is elevated. In the day of admission, it is around 26.4, which was slightly reducing 22.1, but is not of much difference. And here, the direct bilirubin, it is almost around, the rise is around almost more than 50%. And enzymes, initially it was elevated, but there is further there is fall in the enzyme levels, we can see. Albumin also, it is in the decreasing trend, even after transfusions. With this, we can make out that there is definitely the liver function is like there is liver injury is decompensated. This is the from all these we work up. This is the like for investigations which shows that liver dysfunction or baby is deteriorating. There is a declining albumin with increasing INR with a declining trend of enzymes, and even there is creatinine levels which was initially elevated with the CBP showing cytopenias of both anemia, persistent thrombocytopenia, and leukopenia. The next workup, it is based on etiological workup. In view of infections, we have sent it for blood culture, which was positive for Klebsiella oxytoca, which is multi-drug resistant infection, and urine for fungal ailments, it was negative. CUV was urine routine examination was normal, and then urine culture was sterile. TOS screening we had sent, which was negative, and HIV, HBS also it was negative. Here we have an as discussed earlier, COVID IgG was positive, but IgM was negative, and D-dimer was elevated with the LDL level, H levels also elevated. We have metabolic, here the he doesn't have any hypoglycemic episodes, and the GRBS was maintaining. Serum ammonia was normal. Lactate was slightly elevated, but it is not much elevated. Urine for ketones was negative, and NBS we had sent, it shows elevated phenylalanine levels, and tyrosine levels were also elevated. Urine for, we had sent the sample for urine for succinyl acetone, but report is awaited. Even the GALT enzyme assay was normal. In the NBS, it was showed phenylalanine and tyrosine inhibitor. We have also sent for whole clinical genome sequencing. The report has to come, actually. Serum ferritin shown in here, it was also elevated, which is 1404 nanograms per ml. Triglyceridemia, it was normal. And USG abdomen, it shows gallbladder sludge with minimal ascites and hepatosplenomegaly with no evidence of IBC and renal thrombosis. 2D echo showing LV dysfunction with small AST with mild TR.
I think we'll pause for discussion here.
Yes, yes. So this baby had a very bad gram-negative organism in the blood. So can it be responsible for the entire clinical syndrome? This appears to be a meropenem resistant, that is carbapenem resistant bug. So these kind of organisms, and you know that these infections are very quite, fatal. They are not easy to treat, and there is an ongoing infection is there. So is it possible that the entire clinical syndrome is Because of that, because there is persistent jaundice, hyperlipidemia, cholestasis, there is severe thrombocytopenia. Especially you have a bug like Klebsiella, which is known to cause severe thrombocytopenia. So have you how do you know that this kind of an organism is there? So I'm interested to know that, when you have this kind of an organism in your NICU, how are you dealing with this case? Because this is a bug which has come into your NICU, and you have to take a lot of protection. And if it spreads across your NICU, then you'll have a lot of problem. Because this is a kind of challenge which all of us face, because we get babies from many kind of hospitals, and this is exactly a syndrome which can fit into that. This second thing is, have we looked at cytomegalovirus? Have we seen whether because cytomegalovirus infection in a premature baby, either it is intrauterine infection or an acquired through the transfusion, can also lead to a syndrome where there can be respiratory failure, cholestasis, may not be having liver failure so early, but we don't know whether this failure is because of the associated sepsis. So it may be good to see whether the urine PCR cytomegalovirus was positive or not. The third thing is that this kind of a presentation can sometimes, how do you know that, how can you say that this is not a graft versus host disease? Can the graft versus host disease can also lead to this kind of a clinical syndrome? What else has to be there to call it as a graft versus host disease? And finally, if you are thinking of hemofibrosis, what other investigations, imaging or elsewhere are required to fulfill the criteria to call this as hemochromatosis?
Hemochromatosis, usually MRI imaging we have to do, sir.
You have to demonstrate extrahepatic iron deposition. Yes. So that's the thing, but it may be difficult for you to take the baby out to get it done. Just the presence of elevated ferritin levels may not be enough.
That's not a diagnostic test. Actually, we had to do MRI imaging of extrahepatic tissues, or we had to take oral mucosal salivary gland biopsy.
So what do you look for in the minor salivary gland biopsy or the lip biopsies?
Iron deposits.
So with Pearl stain, you will be able to demonstrate iron deposits in the minor salivary gland. So typically a lip biopsy is considered more specific for demonstrating NH. And as sir rightly pointed out, elevated ferritin is a very non-specific marker for NH. It can be elevated in most of the other infections, inflammation, and per se in liver failure due to other etiology. I think we had a similar case when I was doing my DM, where we were led into thinking that a term baby with a similar history, multiple previous sibling deaths, baby coming with ALF and hypoalbuminemia ascites with very high ferritin. We almost thought it was NH, and even one double volume exchange transfusion was done, but later turned out to be galactosemia. The enzyme workup came back showing very much decreased enzyme levels, and the baby did very well with lactose-free diet. So ferritin can be very non-specific and misleading. So a lip biopsy is something which is very specific. Yes, there can be bleeding, but still remains the most preferred diagnostic modality. Of course, most of these babies are sick, and shifting them for an MRI can be a very difficult task. I think the other pertinent question that sir had asked us was regarding the management of a baby who's presenting to our unit with multi-drug resistant sepsis, like this baby with GNB sepsis. So what are all the steps that you should take as the doctor managing this baby to make sure that we don't end up with horizontal transmission?
First, hand hygiene we had to.
Right. So hand hygiene, not just talking about it as a matter of theory. We should be obsessed and fanatical about hand hygiene. So there should be absolutely zero tolerance to missing any of the steps of hand hygiene, and it's a must that we do hand washing with soap solution when there is a baby with proven or culture positive infection. Then there is absolutely no role of hand rub. Then it has to be hand washing between patient contact. Now, barring hand washing, what is your take on barrier nursing? So what all would you do to ensure that there is complete barrier nursing? What do you mean by barrier nursing?
Only one.
So it means, yeah.
Complete like isolated nursing should be there for nursing care should be there only for that baby. Whoever is taking care of that baby, they should be very careful, and it should be only limited to that.
Right, 1:1 nursing, and not just the nurse, but in terms of each and every disposable that we are using. So be it the hand care, be it the stethoscope, the thermometer, inch tape, linen. So everything should be used exclusively one-on-one, and the set of items that we are using for one baby should never be brought near the other baby. So there has to be complete barrier nursing. So do you think the baby also needs to be managed in isolation?
If yes, ma'am.
So preferably the babies with multi-drug resistant infection, more so if they are aerosol based transmission. So when we had COVID, you all know that we had managed babies with suspected or confirmed COVID with in isolation, typically with a physical distancing of 6 feet or 2 meters. And ideally, if the situation permits, should it be negative pressure or positive pressure in isolation area? It should be of negative pressure, so that the air from that area does not go into the other surrounding bays of the NICU, so that there is complete airborne isolation precaution also being taken. And as you said, the role of hand washing and the role of barrier nursing becomes very, very important when you're dealing with babies with culture positive infection, and this has to be repeatedly reminded to our team, to our nurses. So I think the other questions sir asked were, can you answer them one by one? So you spoke about diagnosis of neonatal hemochromatosis. So the other thing that sir rightly asked us was, could the whole thing be, the whole syndrome be due to sepsis and multi-organ dysfunction per se?
Maybe.
So
Yes, I have asked about it because I think unless you demonstrate that this baby is free of that bug, it's so difficult to say that this is not because of that.
absolutely.
Yeah, this is very, very, because I hear this kind of, it's not the first case. I hear from various parts of our country with this kind of a presentation, and they are dealing with these persistent infections. they go on for a very long time and it is very difficult to treat them. So you don't know whether you're dealing with a second condition or it is all because of this carbapenem resistant infection.
Very true. I think very difficult to kind of draw the line and say whether this is all because of sepsis or because of other more complex etiology that we are suspecting, because it never seemed like this baby actually responded to the antimicrobial treatment. So the factors for persistent signs of sepsis, despite so-called appropriate antimicrobial cover, like appropriate dose, appropriate, of course, route of delivery, appropriate frequency of delivery. All these things have to be repeatedly checked. We have to check for medication prescription error. It's a good idea to sit and discuss with our microbiology team whether we are on the right track, whether there is anything else that is to be done. Removal and replacement of invasive devices, if they were present at the time of isolation of the bug, can be another useful strategy. So if we see non-resolving signs of bacteremia, if there is a central line in situ, if there was a urinary catheter in situ, it is a good idea to get the invasive device replaced and to look for concealed sites of infection. If the baby continues to isolate the bug repeatedly, then the sites that are to be screened specifically for include the heart for any evidence of infective endocarditis. Is there an abscess sitting somewhere within the abdomen? Is there an intra-abdominal abscess? Is there an intracranial collection? So these are all things. Or is there a bone and a soft tissue infection? So these are occult sites.
So have we sent the multiple blood cultures in this to see that you're not growing it again?
I don't think we did not repeat a blood culture, sir. This was the baby stayed with us for around 6 days.
Admitting culture was positive. So since how long this child is there with you?
The baby stayed with us for around 6 days, and then they kind of decided to discontinue management, and they have taken the baby to Nilofer after the genetic workup sample was sent. So they stayed with us totally for around 6 days.
So one more way to say whether this baby has a bug or not is doing a PCR for the bacteria, because sometimes the blood culture may not be positive. The PCR is also not very sensitive, because if you have a low level of bacteremia, may not be able to tell. But when you have this kind of a bug, which is isolated, this particular clinical syndrome is possible.
Agreed, sir.
Hello.
Then few questions, both actually few questions and few suggestions. Till now all the investigations have gone through extensively and exhaustively, completely evaluated well. So the way we neonatologists normally, we actually see any baby with a sepsis and multi-organ failure, we are anxious about sepsis. But this baby is the way presented with the 5 antenatal morbid history there, G6 probably, and aberration, recurrent aberration. And babies anhydramnios, IUGR, and AEDF. I think this disease started in utero. So my focus will be evaluation diseases which starts from in utero, which helps. Additionally, because of our care in intensive care, getting an organism, bad organism is a possibility later, which deteriorated for the deterioration of the condition happened. But for antenatally to know hereditary or familial or recurrent infections, so we discuss about TORCH. So detailed evaluation of all the panel of TORCH, which can cause recurrent pathology, is required, which Dr. Ravi Shankar sir suggested CMV, so Harfish, other parameters we are doing, IgM is good. And here the new era, the COVID, only doing the antibody of the baby many times because of the vaccination, because of the past infection of mother, we get positive in the early phase, first 1 month neonates, we get IgG positive. So distinguishing IgG, IgM or double titer or maternal titer, baby's titer can help here. So that's otherwise always creates a confusion of inflammatory disease. We cannot conclude here. But I'll ask one question, 1 or 2 investigations which can little bit give a clue. Dr. Srijan.
Hi, sir.
We have done the investigation DCT, direct Coombs test, to know was there a immune phenomenon.
Yes, sir. Actually, we had done that.
Done direct DCT?
Yes, sir. Done, sir. It was negative.
Negative or positive?
Negative, sir.
Negative. So immune phenomenon, we cannot exclude sometimes if the high antibody titers are there, frozen phenomenon, but still we have done, it's negative. Then second, the reti count, the bone marrow, always the hemoglobin remain low, concentrate. So reti count also done in the meantime to know about the bone marrow function.
We didn't do, sir.
Okay. So ascites was there prominently in the picture. So did we do the ascites analysis to know the protein albumin of the ascites, blood ascites comparison of to know exudative form of due to sepsis, exudative form of ascites or a transudative form of ascites? Do this investigation we have done?
No, we didn't do, sir.
Then the metabolic cause, which is the next differential diagnosis after the GALD, which is we say normally common word neonatal hemochromatosis. We should not create a confusion because primary hemochromatosis is a genetic disease. Neonatal hemochromatosis is autoimmune disease. So this is a complete different pathology. So that part, so definitely it is there. But so we metabolic cause is the next one. The way you have evaluated TMAs, urinary organic acids, definitely required. But if you do a simple test which can differentiate between the 3 common diseases which can cause with hepatic failure, like reducing substance in urine. Simple. I'm not talking about glucose oxidase method. Conventional Benedict test of reducing substance in urine.
Actually, we had done, sir, reducing substances. It was negative, sir. I forgot.
So just I'm asking because this will clarify in weighting or urinary organic acids weighted. So if a succinylate stone comes or anything comes, metabolic acidosis marker, organic acidemia, it will give the diagnosis. But before going to that, simple investigation might sometimes help. So if these investigations we know, few of the things we can exclude, then I'll coming to the management. I will ask one question. We are not clearly know about the evidence, but whenever GALD, the way the story built here, recurrence history, antenatally started the pathology, later multi-organ failure with autoimmune phenomenon. So before giving IVIG, any exchange transfusion in the previous hospital or current hospital tried anytime?
No, sir.
No exchange transfusion tried. Okay. So that's maybe another thing might help, but we don't know that it can help or not. We don't know. But early part exchange transfusion IVIG might help in the autoimmune disease. The remaining, the last question I will ask, which already discussed, well highlighted by Ravi Shankar sir and Dr. Aparna also given the right point because we are anxious about that. Here I will say one thing. Klebsiella oxytoca is just a multi-drug resistant Klebsiella, and the organism is only sensitive to tegicycline. But as per the pharmacology, we know tegicycline is a bacteriostatic medicine, not a bactericidal medicine. And aminoglycoside also a bacteriostatic medicine. This organism is sensitive to 2 of the bacteriostatic, none of the bactericidal agents. So how, as a neonatologist, we have to optimize the case. It's sensitive to bactericidal, but if a multiple bacteriostatic combination might not help. So how we will investigate this particular baby if we'll get a multi-organ, multi-drug resistant, only sensitive to bacteriostatic? Can you go for that bacteriostatic agent, or we will optimize by some investigations and protocol? So then the last question, the antibiotic question, what I'm asking, so do we go for only multiple combination of bacteriostatic medicines, or we investigate some specific investigation in carbapenem resistant organism, and so we can optimize the antibiotic protocol?
We had to further go, sir, but
done. So probably we're waiting for investigation. Genetics investigation can help this baby's diagnosis, and lead biopsy could have helped this baby's, and already metabolic investigations. And with the investigation, probably will know the disease, but it's a well investigated baby. And
do we have any experience with the genetic testing in this carbapenem resistant organism? Anybody has done this here? Only?
Yeah, it is available. I'm asking for that reason because nowadays we are getting really, the way you are anxious, Dr. Aparna also anxious. When we are getting the referral now from outside, we are getting these bugs, gram-negative resistant to even tegicycline. Now we are getting colistin. Initially we got carbapenem resistant, then we got the colistin resistant. Now we're getting tegicycline resistant also. And the issue with the tegicycline, if an organism not known, it won't cover few of the ICU bugs, and it is a bacteriostatic drug. So we are doing gene expert carbar resistance pattern analysis, which sometimes guide us actually. If the baby, we are not in the right track and we are treating with higher antibiotics, carbapenem resistant drug, we don't have any answer which is the right antibiotic. Sometimes this Carbar gene analysis we do, it's available commercially in Hyderabad. So if you do different labs, not only one lab, multiple labs are doing nowadays. So that gives the diagnosis, sometimes the clue which antibiotic to rightly choose, because it's really for tertiary level NI issues, it's really now we're anxious about this multi-drug resistant organisms. I don't want
the
to...
other problem was that with colistin, some of the bugs, especially the the CLSI actually recommends when they do the laboratory surveillance, microbiological surveillance. As per the CLSI guidelines, they are mandating that some bugs be reported sort of resistant to colistin, even if the MIC, the minimal inhibitory concentrations are very small. This happens with pseudomonads like Burkholderia or pseudomonas like organisms, Serratia, etc. Even if the MIC is 0.5, it's small, it is reported to be resistant as per the CLSA guidelines. In this baby also, with this Klebsiella oxytoca also, the MIC came out for colistin relatively less. So, but when we discussed with our microbiologist, she was not in favor of using it upfront. So this again is a point of contention, and we may be able to get better answers by testing for the gene responsible for bacterial resistance. But it was a struggle to kind of achieve the right kind of antimicrobial regimen for this baby with multiple ongoing issues. We also did upfront consider that this is probably very likely to be a genetic metabolic reason for the acute liver failure because of the history of consanguinity, previous 3 spontaneous abortions, and of course 1 medically terminated pregnancy. And in this pregnancy, there was evidence of anhydramnios, some placental insufficiency, AEDF. And it looked like the baby was started on minimal enteral feeding, and some progress was made on enteral feeding. Then the symptoms of liver dysfunction kind of set in. Of course, the elevation of phenylalanine and tyrosine in the newborn screening may still not be diagnostic of tyrosinemia, because these were actually sent after a certain duration of fasting. We did not find very much elevated levels as we would have expected in a classical case of tyrosinemia. The genetic workup should hopefully give us more answers.
So I think for a PG, it's very important that, to deal with such a kind of case is they have to be quite, cautious. Apart from all the possibilities which we have, discussed, I'm worried about the resistant organisms spreading everywhere, because that's what is actually. And if you do not take a proper isolation or a contact isolation practices, then your unit is going to get more organisms, and the normal babies will develop these kind of infections, and it will be difficult to get rid of it. So this case not only highlights about the various ways in which we have to approach a case of hepatic failure, but it also tells us that we when we have a difficult organism, we have to be extremely careful about it, and it is not an easy illness to cure. So I think we are done with the case. Any others? We have anything in the chat box?
That's also just only few like a discussion. What all we discussed, it was.
I think, Srujana, we have discussed actually most of these points while discussing the case. I think extensively all the individual etiology also was discussed. I think specific management may not really be of great value to us, but do you want to just tell the principles of management, general management of liver failure in a newborn? Can you just elucidate all the principles alone? Don't go into specific management modalities like DVT or
Yes.
NTBC for tyrosinemia, etc.
General principle first, coming to fluid management, there should be restriction. Fluid restriction should be there. Almost around 2/3 of maintenance we had to give. We had to say cerebral edema we had to keep in mind. Then coming to protein, protein also, if there is any metabolic causes and all, based on that we had to restrict the protein. Otherwise 2 to 3 grams we can give. Then coming to other thing, the cholestatic regimen we have added, which includes vitamin A, D, E, and then vitamin K. It has to be given either weekly once or daily basis. Then coming to the we had to monitor acyclovir was already discussed. Acyclovir in view of HSV infection until it is diagnosed, we had to start. And then lactose-free formula till GAL1 enzyme levels were negative, we had to start. As there are more these type of people, they are more prone for infection, so we had to start prophylactic antibiotics and antifungals should be started. And for gastroprotective measures, we had to start on ranitidine 2 mg per kg twice daily, and glucose. Continuous monitoring of glucose has to be done because most of these type of cases they may present with hypoglycemic episodes, and the urine output has to be monitored regularly, and the vitals has to be monitored. Electrolytes, it has to be monitored daily, at least twice a day has to be.
That's okay, fine. I have one last doubt. Did we do the procalcitonin in this case?
We didn't do, sir, actually.
Procalcitonin. Because sometimes the procalcitonin is helpful to know whether it is helpful to us to stop the antibiotics. Because if the procalcitonin is low, then we know that infection is under control here. Okay, I think we are done. Anything else, Aparna? You want to present us something more, or
no? Not really, sir. I think we have covered most of the important aspects. Yes. I think we can, if you and Dr. Nalini have any further comments, we can go through it, or if not, we can hand over to the organizers.
Well, I will say this well-evaluated babies, condition well-evaluated. Challenging case always when it comes with a multi-organ involvement and going to multiple causes, all investigation workup to be done. And sometimes we get diagnosis, sometimes the genetics level may give you a diagnosis later, but the evaluation should be key so that we can cover all the etiologies. That's the key message I will say. Many times with such a sick baby, we may not be able to stabilize the baby, we may not survive, but the investigation workup will teach us later how to go for early diagnosis or later cases. We can apply those principles, we can get the diagnosis early. And this is probably the message here, the evaluation part. And second, as Ravi Shankar sir told, procalcitonin, probably I won't dare to stop antibiotic knowing Klebsiella oxytocin sitting there in my first, whatever the CRP value, whatever the procalcitonin value, if the blood culture is there, I will at least 14 days, we cannot stop with the sick baby. So in absence of blood culture, probably those investigations might help. In presence of blood culture positive in the blood, some organism, probably our compulsion is to continue the antibiotic, we cannot stop it. That's probably.
Bhaskar sir, are you there?
Yeah, I'm here.
Okay, fine.
Dr. Aparna, you said you're going to present briefly. Would you like to do it, or?
I think, sir, Dr. Srujana has covered the presentation of acute liver failure also, and it's already around 11, sir. So I think we will conclude here.
Yeah, thank you. Thank you, Dr. Aparna. Dr. Srujana, you've done a great job. And it's an interesting and very complicated case. Despite that, you had presented so well. And I know that you are given a very short notice. You had less time and you are busy in your institute, in your unit. Despite that, you did a great job. And I'm sure you are going to have this a great experience, a memorable experience for you. And things will make easier for you in future. Secondly, I appreciate our experts. I'm so happy, our entire EB is so happy to choose these experts with their wisdom, the way they participated in the discussion for 45 to, I'm sorry, it's 1 hour 30 minutes, listening and discussing, questioning and responding and not hurting this speaker. I mean, the presenter, they have shown their complete expertise in handling the case. And thanks to Dr. Aparna for coming in between and helping the mentor and briefly summarizing the case. That had done a great, I mean, things had made, you made things more easy for the viewers to recapitulate the case history or findings or the treatment. So I sincerely thank the participants. So many are there still until this last minute. And amazingly, most of them are very senior pediatricians. That shows the interest they have. And our PGs probably they had worked so much during last 7 days. They want to take rest today. Or they know that it's going to be presented on YouTube. It is there on YouTube. They can see it and they can learn many things from this PG Clinics. Yeah, so thank you all for attending this PG Clinics. Sunday. I wish you all a very happy, pleasant Sunday. And special thanks to Dr. Aparna, Dr. Nalinikant Panigra, and Dr. Ravi Shankar, of course, Dr. Srujana and the senior participants, Dr. Tilak Chandrapal, Dr. Anand, Dr. Tiwari, Dr. Srinivas, and all the other participants. Thank you one and all for helping IAPTCB to do these academic activities. In future, looking forward for the same support and cooperation from you. I wish you all a very good day. Thank you.
Thank you. Thank you, Bhaskar sir. Aparna, could you stop screen share?
Thank you, sir.